Erev Tov, it's good to see everybody. Hope everyone had a nice Thanksgiving, and thanks for coming out on this rainy evening. But it's warm in here for a number of reasons. Always because when we get together, it's nice to be warm, but also because we get to come together for a very special program as part of our TBS Bioethics Initiative, which now, as of tonight, is going to be renamed the Dr. Jeffrey Kramer Bioethics Initiative at Temple Beth Sholom. In a few moments, Yael Asbel is going to speak a little bit about the initiative and about Jeff before we continue on with our main program. But I will just begin by welcoming everyone here tonight. It's good to see everyone here. I want to give a special welcome to Dr. Kelly Sorenson of Ursinus College and his students who we brought with him from Ursinus. It's good to have you here, and thank you for making that trip over here tonight. And Kelly's a wonderful partner for our Bioethics Initiative and has helped us out with programs and input as well, and it's great to have you here tonight. We're also very happy to have with us tonight Dr. Steve Joffe from Penn, who is going to be our featured speaker, who Rabbi Lindeman will speak about a little bit later. I also want to give a special toda rabah, special thank you to Steve Bornstein, who, as always, helps us out with the sound and makes us sound good up here, right? It's all because of Steve. It's nothing that we do. And big thank you to Jill Hamill as well for putting all the pieces together, and to Greg Bannett and to Yael for helping to help plan and to put together this program, amongst many others. Also, special welcome and a big toda rabah to Jane Kramer and her family who are here tonight, including Jane and Jeff's children, Rachel and Rob, Allie and Dave, and Evan, amongst other family members. It's wonderful to have them here tonight for our very special evening. I just want to point out, before I forget, that our next bioethics program, because before this even starts, you got to mark your calendars for the next one. Our next bioethics program is about the ethics of end-of-life care. And it's going to be on January 31st, Thursday night at 7 p.m. here. And it's going to be featuring Dr. Sandy Buckman, who is an associate professor in the Department of Family and Community Medicine at the University of Toronto and is currently putting together the very first Jewish hospice in Canada, along with Rabbi Michal Springer, who is the director and founder of the Center for Pastoral Education at the Jewish Theological Seminary at JTS, which is our partner in these Bioethics Initiative programs. So we hope you can make it out on January 31st for that program. There are flyers on the tables outside. Finally, I just want to note that as part of our dedication of the Dr. Jeffrey Kramer Bioethics Initiative, you'll be seeing very soon in the library, in our Rabbi Lindeman Lifelong Learning Center, it just never gets old. It never gets old. A plaque just like this, which says the Dr. Jeffrey Kramer Bioethics Initiative, dedicated in memory of Dr. Jeffrey Kramer, honoring his commitment to Torah, medicine, and the Jewish people, November 26, 2018. And by this plaque, you'll find books on bioethics, on Jewish bioethics, Jewish medical ethics that we have in our library and that we'll be acquiring. It'll be a nice space that we'll have in our library, honoring our initiative and honoring Jeff's memory, and being able to help us study more and think more about these very important conversations that we have here around bioethics. And so to help us reflect a little bit on this evening and on Jeff's memory, I'm going to invite up really our one of the visionaries of this initiative who worked closely with Jeff and with Greg to help make this initiative a reality, Yael Asbel.
Thank you, Rabbi. The genesis of bioethics at Temple Beth Sholom began several years ago with a joint presentation by Rabbi Danny Nevins, who is the dean of the rabbinical school at the Jewish Theological Seminary, and Dr. Arthur Kaplan, who was then at the University of Pennsylvania. The success of that program inspired the planning for a bioethics initiative here at TBS. Our goals, which I developed with Rabbi Lindeman and shared on his recommendation with Jeff Kramer and Dr. Greg Bannett, were: 1, to respond to strong congregational interest and a greater understanding of the intersection of science and religion. 2, to teach the lessons of Torah which can be applied to contemporary scientific achievements in the practice of medicine. 3, to learn with scholars of the highest caliber and to interact with members of our congregation who are healthcare professionals. And 4, to consider the ethics of patient and pastoral care issues. These goals were crafted with Dr. Joffe Kramer in mind. From the beginning, Jeff was so excited about the project and was fully committed to its success. Anyone who ever worked with Jeff on anything knows it was impossible to outwork him. I provided the inspiration, Jeff provided the perspiration, and we both liked it that way. One of Jeff's first steps was to reach out to tonight's guest speaker. Although Dr. Joffe was not available to come to TBS at the time, Jeff skillfully enlisted Dr. Joffe for guidance to find those scholars who would meet our expectations. Many of you will remember our first program with Professor Arnie Eisen, Chancellor of JTS, and Professor Jonathan Moreno of the University of Pennsylvania. That program was, in Jeff's own words, a wonderful evening, a major success. We've started a critically important dialogue which should be emulated everywhere. The Chancellor was so impressed with Jeff's efforts that he unsolicitedly suggested an ongoing partnership between JTS and TBS. This is unprecedented. Soon thereafter, JTS produced a series of ethics programs for distance learning, which we taught here. The rabbinical school curriculum at the seminary now includes bioethics. We have made an impression by what we're doing here, and Jeff would be very proud of that. Jeff's contributions to the Bioethics Initiative earned us great wisdom and honor, so it's only appropriate that it bear his name in perpetuity. Early last year, his sister wrote to me, quote, "I cannot fathom how you could have come up with such a brilliant concept, melding his two great interests, Judaism and medicine. It has kept his mind so stimulated and passionate during a difficult time." I got the invaluable opportunity to work closely with Jeff. That was the best part of it for me, to spend an enlarged amount of time with him, and during that time to focus on bioethics programming, something that he had clearly made his own. What an incredibly rich experience, and I'm grateful for that. Jeff consistently deflected credit to others for his success. Only 24 hours before he died, my friend Jeff Kramer wrote to me. He asked me to excuse his brevity for the email. He had little energy. He was writing to express his gratitude for having been involved in the Bioethics Initiative and what a joy it had been to him. He said that Rabbi Lindemann had just come by to tell him that the Bioethics Initiative here at TBS was to be renamed in his honor as the Dr. Joffe Kramer Bioethics Initiative. Even though his modesty demanded that he tell me that credit was due to others, he humbly accepted the honor. It left me with my final thought of Jeff, that even in his final hours, he was someone who I wished I was a lot more like. Thank you.
Thank you, Yale, and thank you all for being here. Welcome again. I brought with me my copy of Elliot Dorff, my professor's book on Jewish medical ethics called The Matters of Life and Death. It's 456 pages. I'll read it quickly. By way of introduction, as you all know by now, the Dr. Joffe Kramer Bioethics Initiative at TBS seeks to explore important issues in medical ethics and understand how Jewish values and texts can inform that discussion. And tonight we'll discuss the right to try, the ethics of experimental drugs, and we are very pleased to have as our primary presenter Dr. Stephen Joffe, the Emanuel and Robert Hart Professor of Medical Ethics and Health Policy and Professor of Pediatrics at the University of Pennsylvania Perelman School of Medicine. More about Dr. Joffe in a minute or two, or a few minutes. First, I want to frame the discussion from the perspective of Jewish text and tradition. The beginning point for this, we all know, that the human body as the human soul is a creation of God. But to come to focus more on the points for tonight, the Torah enunciates two principles that must be balanced. In Deuteronomy chapter 4, the text says, "V'nishmartem ma'od l'nafshotechem," guard your life very carefully. This can be read as a caution to avoid anything that may put your life at risk, which could certainly be applied to experimental treatment of any sort. And then later in the book of Deuteronomy, in chapter 30, we find the imperative, "Uvacharta v'chayim," choose life. This seems to suggest that in a case where experimental treatment offers the best hope, one may actually be obligated to pursue it. And then there is this text from Leviticus 19, "Lo ta'amod al dam re'echa," do not stand idly by the blood of your fellow. This can be understood as a directive to those who are responsible for providing treatment or making it available. All of these texts, it should be noted, are taken from their original contexts and applied as general principles in ways that considerably broaden their scope. So now let's move from the biblical period to the Talmud, a jump of about 1,000 years. Interestingly, the relevant discussion takes place in Masechet Avodah Zarah, idolatrous practices. Rabbah said in the name of Rabbi Yochanan, when a patient will possibly live and possibly die if left untreated, we may not take medical practice from pagan practitioners. But when the patient will surely die if left untreated, we may take treatment from them. Now, I am certain that we could have a lively discussion about how to apply the designation pagan practitioners. Perhaps that applies to doctors from a different practice from your own, or maybe to an alternative medical culture. Certainly at the time of the Talmud, this teaching suggests a connection between medicine and religion, and some concern about which god or gods might be seen as responsible for healing. You don't want people getting too close to pagans for any purposes. It might lead to mixed dancing. The Gemara goes on to raise a question on the matter, that is, the medical matter, not the dancing, saying, if there is chayei sha'ah, momentary life, remaining, do we risk that by seeking treatment from pagans who aren't to be trusted for either their intentions or their methods? And the answer is given. We do not concern ourselves with momentary life when there's a possibility of long-term extension of life. And clearly, this supports the idea of accepting some risk for extending life, though it is important to point out that chayei sha'ah, momentary life, is a vague term. Do we take it literally, meaning that death is imminent? Or is it to be understood more loosely as indicating that death will occur in a short but indefinite period of time, perhaps weeks or months or even a year or so? In any case, the Talmud's teaching is accepted by two of the most important later law codes. In the Mishnah Torah, Maimonides, who was a doctor as well as an authority on Jewish law, says that it is prohibited to take treatment from a pagan practitioner unless we have given up hope that the patient will live. But then he goes on to add that if we see that this practitioner has a drug that seems to be of some benefit, we may ask the ingredients in order to duplicate that medication. So it seems that the right to try was already under discussion in the 12th century. A similar position is based on a discussion of end-of-life treatment in the 16th century Shulchan Aruch. A commentary by Rabbi Yehuda Eger applies the Talmud's teaching that where death is imminent, we can take risks on drugs or surgical procedures that may extend life, and this is cited in responsa literature through the 18th and 19th centuries. All of this leads modern scholars on Jewish medical ethics to conclude that where no other cure is possible, one may try even risky therapies in order to extend life. This is the position taken by Orthodox, conservative, and Reform authorities. Dr. Emanuel Jacobowitz, in his book Jewish Medical Ethics, Dr. Fred Rosner, Modern Medicine and Jewish Ethics, Rabbi Basil Herring, Jewish Ethics and Halakha for Our Time, all follow this tradition of interpretation, though they differ in their perspective on the length of time implied by the Talmud's term Chayei Sha'ah, the limited life remaining, before an experimental or high-risk therapy can be undertaken. My teacher, Professor Elliot Dorff, prefers to state it this way: Jews may employ such therapies where no known cure is available. This clearly extends the term Chayei Sha'ah well beyond momentary life. But Rabbi Dorff, like all the other scholars, holds that the first recourse should be to conventional treatments. In reflecting on the right to try, Rabbi Dorff would also point out that the matter must be considered both from the perspective of the provider and the patient. He holds that Jewish ethics would require that experimental procedures and drugs be available on the basis of the Torah's teaching that one may not stand idly by the blood of his fellow. Furthermore, the Talmud teaches that where there's any chance of saving a life, for example, a person who is drowning or may be attacked by bandits, one must intervene, even if there's a risk involved and we do not know the chances of success. Thus, a society could be required to provide access to experimental or risky treatment. However, the ultimate decision to risk such treatment always devolves upon the patient. For Dorff, this is not only a matter of duration of life, but also quality of life. Factors such as pain, fear, emotional impact upon loved ones are also to be considered, even in decisions about conventional therapies. In short, the patient has a right to try, but there are qualifications and criteria that must be met. So now, with this context from Jewish thought, it's time to hear from our guest, Stephen Joffe. Dr. Joffe is a pediatric oncologist and bioethicist who is currently, as I said, the Emanuel and Robert Hart Professor of Medical Ethics and Health Policy, Professor of Pediatrics at the University of Pennsylvania Perelman School of Medicine. He is also the director of the Penn Fellowship in Advanced Biomedical Ethics and the Penn Postdoctoral Training Program in the Ethical, Legal, and Social Implications of Genetics and Genomics. Dr. Joffe's research addresses the many ethical challenges that arise in the conduct of clinical and translational investigation. He's authored over 100 articles addressing these topics. He serves as a member of the FDA's Pediatric Ethics Subcommittee, the National Institute of Health Clinical Center Board of Scientific Counselors, and the National Human Genome Research Institute Genomics and Society Working Group. Dr. Joffe was educated at Harvard College, received his medical degree from the University of California at San Francisco, his public health degree from UC Berkeley. He trained in pediatrics at the University of California in San Francisco and undertook fellowship training in pediatric hematology oncology at the He is an eminent scholar in this field, and we are thrilled to have him here with us tonight, Dr. Joffe.
An eminent scholar who almost tripped and fell on his face on the way up the podium. Clearly, I don't do this enough. First of all, let me say that it's really an honor to be here tonight at this event that's remembering and honoring Jeff Kramer. Jeff and I spoke a number of times on the phone and had the opportunity to help him as he thought about how to get the bioethics program get started. Sorry I never got to be here at a time when I could actually meet him in person, but on the other hand, the privilege of being here at a time when I could honor him and share in his memory is really important to me. So thank you for having me be part of this. I also want to, I'm going to just show a few slides as I talk. So just get these up. We will. I expect it's coming. Yep. Not going to throw a lot of text at you. Thank you. I want to start by saying we're talking about the ethics of experimental drugs, and we're going to be talking about it in the context of drugs for people who have really bad diseases and for whom there aren't a lot of good options that standard medical care has to offer them. And we're talking about it in an event that's honoring Jeff, and so it's not an abstract thing. It's a real thing that affects real people. And I just want to place my remarks in the context of the fact that these are real people who are dealing with the sorts of things that we're talking about. Sometimes this sounds abstract and a little bit distant, but I want to acknowledge that it's in the context of real people dealing with real issues. What I'm going to be talking about tonight is really a genuine dilemma. On the one hand, we want to be sure that the drugs that our doctors, when you go to the doctor, the drugs that your doctor is prescribing or the treatments that your doctor is prescribing for you, that there's an evidence base behind them, that we know that they're safe, that we know that they're effective, that we can say something about what they're likely to do. You all want that when you go to the doctor, when your family goes to the doctor. But on the other hand, when we have diseases for which there's really nothing that's good out there and we're really threatened by those diseases, we want access to things that might help us as quickly as possible. And the theme of my remarks tonight is that those two things are really going to be in tension. It's really hard to have both of those things at once, and you've got to go in one direction or another to struggle with. Are we going to prioritize access? Are we going to prioritize the need for really good evidence to know that the drugs work? So keep the dilemma in mind as you listen to me over the next half hour or so, and then hopefully we'll have time for a conversation about it. Actually, I always like to know my audience, and so I'm curious, how many people in here are involved in healthcare in one way or another? Oh my. I guess I should have asked it the other way. How many people here are not involved in healthcare in one way or the other? And any lawyers in the room? Because as you'll see, there's a little bit of legal stuff that's going to come up. So if I get anything wrong on the medicine, there's plenty of people here who can correct me. And if I get anything wrong on the law, there's a few of you who can tell me where I went wrong as well. All right. First thing to think about. We don't often think when you go to the doctor, like, so what does it take for us to actually get access to that drug that the doctor might want to prescribe for us? And really, there are 4 pathways to getting access to a drug. And let me just, as background, summarize them. The first is the most obvious one, which is that the drug has been shown to be safe and effective, and the FDA has said, yep, this drug is safe and effective for a particular use. And so we, the FDA, are going to approve, the manufacturer can market it, can sell it, and doctors can prescribe it. Once a drug's on the market, the doctor can prescribe it for the things that the FDA has approved it for, but can also prescribe it for almost anything that he or she would like to prescribe it for, subject only to the patient's consent and the risk that if you do something really stupid and somebody gets hurt, somebody's going to sue you. But doctors don't have to only prescribe things for the things that the FDA has approved them for. But let's say, because we're talking tonight about experimental drugs, let's say we're talking about a drug that's not yet approved by the FDA. It's still in the process of being studied. How could you get access to that drug? And the first way would be to join a clinical trial, right? The FDA has said, we approve the study of this drug. You can't just company can't just market it and sell it, but we approve the study of the drug to figure out if it works, to figure out what its safety profile is. So that's way number 2, join a clinical trial. What if there is no clinical trial? Or what if the clinical trial is halfway across the country? Or what if, for whatever reason, you're not eligible for the clinical trial? Well, the third pathway is what is called expanded access or compassionate use. And that's, you're not formally in a research study, but you get a sort of one-time approval from the FDA to say, yep, you can have access to that drug, not as part of a trial, but just because there's a reason that you might need it and you can't get it in a trial. That's pathway number 3. Pathway number 4 is right to try, of which it's a brand new pathway. It's only a few months old. I'm going to say more about it in a moment. Let me back up to the expanded access, right? This is where you can't join a trial, the drug's not approved, and yet there's reason to think that this drug might be helpful for you. So what does it take for you to get access to the drug under this expanded access pathway, which has been in place, I think, since the 1980s? Well, the first is that you need a licensed physician who's willing to request it from the company, excuse me, and who's willing to prescribe it. That's number 1. Second is you need a company that makes the drug that is willing to give it to you. And this often turns out to be the real barrier, that the companies, for all kinds of reasons, some legitimate, probably some not, say, no, sorry, we can't do this, we're not willing to prescribe it. But the company, nobody's forcing a company to do it. The law doesn't force a company to do it. They have to say yes willingly. The third is that an institutional review board has to approve the administration of the drug. The fourth is that the FDA has to say, yes, you, the doctor, or you, the patient, can have access to this drug. And the fifth, of course, is that you have to consent to receive it, either on your own behalf or on behalf of your kid or something like that. So those are the things that are required. So the FDA has some rules that say when will they approve access to an expanded access or compassionate use drug. Expanded access is the formal term. Compassionate use is the kind of lay term that's often used. So the criteria are: patient has a serious disease or condition, or their life's immediately threatened by a disease or condition. So that's number 1. 2 is there's no comparable satisfactory alternative therapy. If there's some great therapies out there, the FDA is not going to say, yep, you can get this experimental thing. That aligns with what what Rabbi Lindemann was saying. There's something standard, you do that. You don't do the experimental, more risky thing. Third criterion is you can't enroll in a clinical trial for one reason or another, because they always prefer that. The fourth is that in their judgment, the potential benefit of that drug for you justifies the risks of that drug. And the fifth is that you're getting the drug won't interfere with the plans to develop the marketing plan for the drug, get the drug approval, get the evidence that is needed to approve the drug. Turns out that the FDA almost never says no. About 99% of the time, doctor requests a drug on behalf of a patient. FDA says, by all means, go ahead. And in fact, in emergencies, they'll approve it over the phone within minutes, and you've got a green light to go ahead. You see these stories, and I've just shown a couple of screenshots here of stories of dying patients denied drugs. It's almost always the company that is saying no, rather than the FDA or a doctor or somebody else. And again, there are some, we can talk more about this at the end if you'd like, but there are some legitimate reasons for companies to say no, including like they don't have any supply because they're only manufacturing a tiny little bit for their clinical trials. But you do see these stories that are really gripping about people who would like access to a drug. They think it would help, their doctor thinks it would help, they can't access it. So what is this right to try? Many of you may have seen in the news in late 2017, early 2018, a lot of news about right to try. Turned out that what it is it was put forward as an alternative way of getting access to experimental drugs, an alternative to the expanded access or compassionate use pathway. It was a campaign that was started by an organization in Phoenix called the Goldwater Institute. It's a libertarian think tank based in Phoenix. Campaign started in 2014. As a sort of side note, Jeff Flake, the senator from Arizona, what his job before he was the senator from Arizona was as the president of the Goldwater Institute. And what they advocated for was laws that would allow patients who had life-threatening disease to access drugs that have passed initial phase 1 testing, I'll say more about that in a moment, without having to get the FDA's approval. So now you would just need the company's approval, the doctor's approval, and your own consent. What do I mean by phase 1 testing? It's very early in the development of a drug where companies may have tested a drug to learn something about what are its most common side effects. What kind of doses are appropriate? Is it appropriate to use 1 milligram of this drug or 50 milligrams of this drug or 500 milligrams of the drug? Because before they start testing it in humans, they may not even know something that basic. At the end of phase 1 testing, we know very little about whether a drug works the vast majority of the time. We don't even know a lot about how safe it is. So it's really early in terms of what we know about a drug. And the Goldwater Institute and the Right to Try movement said, we think patients should have access to drugs even that early. All it requires, again, is your consent as the patient, the physician being willing to prescribe, and the company willing to provide the drug. And the main difference from the expanded access or compassionate use that I talked about a moment ago is you don't need the FDA's approval. So this was the Goldwater, this is just a shot from the Goldwater Institute's homepage, and saying everyone deserves a right to try. They were implying that the expanded access pathway wasn't good enough and you needed this other pathway. I want to show you a brief video. They produced some videos trying to make the case for a right to try. And it's just about 2 minutes, and I just want to show it to you as an example of the kind of arguments that they were putting forward and the kind of stories that they were putting forward to try to make the case. And I'll say more about who the people are in a moment.
I'm Laura McLinn. I'm the mommy of Jordan McLinn, who has a dream one day of growing up to be a firefighter. The day that we found out that Jordan had Duchenne was probably the worst day of our lives. We were not expecting that kind of news.
Duchenne is muscular dystrophy.
We had been going to the doctor because Jordan just wasn't growing. And so we started with an endocrinologist, and one thing led to another. I remember my husband asking, "Are you sure that he has this?" And the doctor said yes. What that means for Jordan right now is that he is probably in the prime of his life. Very soon, if he doesn't get some special treatment, he's going to start declining physically. He will probably, without treatment, be in a wheelchair within just a few years. He doesn't have a normal life expectancy. That's really hard as a mom to know that your child might not be able to achieve those dreams because of a disease that would hold him back, not because of lack of ambition or desire, but just because there's something physical going on in his body that won't allow it. Without right to try, if the FDA doesn't approve the drug that he needs in time, obviously time is not on Jordan's side. And without access to the drug sooner rather than later, it's not going to help Jordan. That's why right to try means so much to us. There is a drug that exists that can help him. It would slow the progression of the disease so that he could actually, he might still have muscle weakness, but he could live a long, productive life. Especially after Right to Try passed in Indiana, we had just this whole new level of hope because Right to Try would give him access to the drug before going through all of those phases with the FDA. A lot of people need your help, not just Jordan, but anyone suffering from ALS, cancer, muscular dystrophy, any kind of terminal illness. You have an opportunity now to help Jordan and help millions of other people who are suffering from terminal illness. Please sign our petition telling the FDA to stop blocking the right to try.
Pretty compelling video, I think you'll agree. By the way, the kid is Jordan McLinn. You probably caught that they're from Indianapolis. They actually got pretty close to Vice President Pence and were frequent visitors to Washington, and the Vice President would take them around. They'd actually stay at his residence. And they became sort of the face, or at least one of the faces of the Right to Try movement, and were actually very helpful in making progress with that law, which I'll talk more about my skepticism of the law, but they certainly helped move it along. By mid-2017, Right to Try had passed in about, I think, 37 states. The problem is, and the lawyers in the room will know this, that it was ineffective because a state can't say, we're going to override FDA federal law. State can't preempt federal law. And so the state can't say, we're going to take FDA out of the equation because the federal government says FDA approval is required. And so attention from the Goldwater Institute and others turned to getting a federal law passed. And this is where there was a lot of attention to Right to Try that really hit the national news over the last year and a half or so. So it was debated in the House and the Senate. It was actually first passed in the House in the fall of 2017, and then a couple of attempts to pass it in the Senate in early 2018 failed. Eventually, it was passed in the Senate in April or May of 2018, and was signed by the president into law. There's a picture of President Trump signing the law on May 30th, 2018. So as of now, right to try is law. That is Jordan McClin in the front, staring at the president. And in the back, I think you can see the guy in the white shirt. I think that's Matthew Bellina. The law was named for 4 people, one of whom was Matthew Bellina, another one of whom was Jordan McClin. Matthew Bellina suffered from ALS. And the ALS movement, or patients with ALS, were also very involved in the right to try movement. Not uniformly supportive, but many were quite involved. I'll come back to this one. So here's the basic problem, again, as I said at the beginning, is that we want 2 things that are in tension with each other. One is we want really good evidence that our doctors are prescribing things for us that are safe and that work. And that means doing clinical research and clinical trials to develop that evidence to show that they're safe, to show that they work. The other is we want patients like Matthew Bellina, like Jordan McClin, to have access to drugs as soon as there's a chance that those drugs might help them. If we prioritize evidence, that means we're going to study things in controlled settings before we release them for wide use. And that means that access is going to be limited mainly to getting them in trials before they're approved for use. If we prioritize rapid access, that means we're going to make them available widely before there's evidence of safety and effectiveness for the use. And that's the dilemma and the tension that we're struggling with. So let me just briefly step back and put this in the context of the history of drug approval in the United States. The story goes back. There were no drug approval laws until 1906. And in 1906, Teddy Roosevelt, who was president at the time, signed a law, the goal of which was to ensure that drugs and foods were unadulterated, and that when there was a label on drugs, that the drug contained the things that it said that it did. Because before that, in the time of patent medicines, people could say anything they wanted on the label. They could put things in there that weren't on the label. They could say things on the label that weren't actually accurately reflective of what was in the drug. And you can imagine that, first of all, people wasted a lot of money, and second of all, people got hurt. So the law only said that the label's got to be accurate and that you can't adulterate your medications. But then in 1938, there was something called the Sulfanilamide Elixir tragedy. And this was a case where sulfanilamide was an early antibiotic. And the company that made it, the Massengill company, the chemist mixed it in a solvent called diethylene glycol. And you probably know from the sound of diethylene glycol that it's not good to take diethylene glycol. And it turns out that it's really not good to take diethylene glycol. And over 100 people died from the toxicity of the solvent that this antibiotic was mixed in. So Congress kicked into action and passed the Food, Drug, and Cosmetic Act, which said that the FDA has to approve things as safe before they can be marketed. Again, FDA didn't have to show that things were effective, they just had to show that they were safe. So that was the law from 1938 to 1962. In 1962, Congress took the next step, and that was because of the thalidomide tragedy, which actually didn't really happen in the United States, happened mainly in Western Europe, in the United Kingdom, and a little bit in Canada, where thalidomide, which was a drug that was marketed for morning sickness for women with pregnancy, it's given to a lot of women with pregnancy, and their babies were born with very, very short limbs. First of all, about 60% of their babies died, and the rest that were born with the very short limbs. You can probably, you may have seen the pictures of that. And in the wake of that tragedy, Congress said to the FDA, we want you to show now not only that drugs are safe, but also that they're effective. And that was the first time that they were given that power. And that was the first time we had this dilemma between let's keep things in the testing phase until we know that they're effective versus let's get people access to them as quickly as possible. That was the struggle. So Congress and the FDA have done a number of things since then to try to balance this dilemma. Let's try to give people access as much as possible without undermining our ability to study drugs. The most important of which is probably an FDA regulation that was put forward in 1992 called accelerated approval, which said, okay, if here was the bar for full approval, we're going to have a really high bar to show that drugs are safe and effective. We're going to create a new bar that's somewhat lower, where we think things are likely to be safe and effective. We're not completely sure, but we want people to have access to them, and so we're going to approve them at that level, requiring that companies go on to study them further so that we get more evidence over the next few years. Turns out that companies are really bad at doing those subsequent studies to actually conclusively show that things are effective, but that at least was the intent. The motivation for this was mostly the HIV epidemic. Think about this as 1992. The epidemic is raging, and AIDS activists are saying, we want access to drugs. The approval process is too darn slow. You got to speed it up. And this was Congress's and the FDA's response to try to speed it up. I want to tell you another story, and this is where the story gets a little bit legal. This young woman is or was Abigail Burroughs. Abigail, in 1999, she was a student at the University of Virginia. She was 19 years old, and she developed a very aggressive cancer of the head and neck called a squamous cell carcinoma. And she got standard treatments for her squamous cell carcinoma. She got chemotherapy, she got radiation, and the tumor just kept growing and kept growing and kept growing. At the time, in the laboratory, people were studying her cancer cells and found that it had a very high level of a protein on the cancer cell called EGFR. And there were some companies that were studying drugs that targeted EGFR. And the hypothesis, maybe right, maybe wrong, was that targeting EGFR might be beneficial for patients with cancers like Abigail's that had these very high levels of this protein on them. And so her family, there were two companies that were making it. One is AstraZeneca that you've probably heard of. Another one is called ImClone, which may ring a bell somewhere in there. The reason it may ring a bell is because that's the company that got Martha Stewart in trouble when she did insider trading in ImClone shares, and that's what sent her to prison. But her family went to both ImClone and AstraZeneca, developing these two different drugs, and said, please give us access to these drugs under the FDA's compassionate use process. And both companies said no. I couldn't find any documentation of what their reasoning was, but both companies said no. And so, frustrated with that, Abigail eventually, very late in her disease, went on to join a trial for one of the drugs. It didn't help her, and she died shortly thereafter that in 2001. Her dad, whose name was Frank Burroughs, started a nonprofit that was called the Abigail Alliance. And the mission of the Abigail Alliance was to advocate for more access or easier access to experimental drugs. The Abigail Alliance and Frank Burroughs said that limiting access to the expanded access program, that was the only way that you could get drugs, made it really way too difficult for patients to get access to drugs that might help them. And the Abigail Alliance mounted a very forceful, if ultimately unsuccessful, effort to try to loosen up the FDA's rules that got to pretty high levels in the courts, as I'll describe in a moment, but set some very important precedents, even though, again, it was unsuccessful. So here's the kind of series of steps that happened with the Abigail Alliance, which I think are quite enlightening. First, they submitted a petition to the FDA, a citizen's petition, and they said, we want you to develop a new approval pathway so that drugs can be marketed and sold by companies based on very limited evidence very early on in their development, if there's a chance that they might help patients with life-threatening diseases and no good alternatives. Such a pathway didn't exist. The FDA was waiting until there was much more evidence before they would approve things for sale. Abigail Alliance said, we want you to approve things very early on. As this petition sat with the FDA, the Abigail Alliance went to court, and they sued the FDA in federal district court in the DC area. And they said that the restrictions on the sale of drugs to people with terminal illnesses violated their constitutional rights to privacy and due process. And as the case wound its way through the courts, it turned on the question of whether patients have a fundamental right in the United States of access to investigational drugs. Rabbi Lindemann was talking a lot about how, as a patient, you ought to think about whether you should agree to, you should look for an experimental drug. He talked a little bit about whether companies or people who might be able to help provide you with the drugs have an obligation to do so. This was focused on whether there's an obligation, on the obligation of others to make those drugs available to you. So the legal question turned on this issue of, is there a fundamental right? The district court, which is the first level of federal court, heard the case and said, nope, no fundamental right. And they didn't even go to a full trial, they just dismissed it out of hand. So the Alliance then went on to appeal the case, and they appealed it to the Court of Appeals for the District of Columbia Circuit, which is one of the most influential circuit courts in the country. It's one level below the US Supreme Court, and you'll recognize some names as I talk about some of the justices in a moment. So initially, the case was heard by a 3-judge panel. I think there were 10 judges on the court. It was heard by a panel of 3 judges. And in a a ruling that shocked people who were following the case. The panel found 2-1 for the Abigail Alliance, saying there is a constitutional right to access to experimental drugs for patients with terminal illness, that it's fundamental and that it's constitutionally protected. And the government, in order to show that the regulations preventing that right from being enacted were valid, the government would have to show that they were narrowly tailored and served a compelling state interest, and the government had not met that burden of proof. And so the restrictions on access were unconstitutional, and the FDA would have to go back to the drawing board and develop much looser guidelines so that patients could access drugs. Talking about end-of-life care, going back to Rabbi Lindemann's talk, in the court's opinion, it said, what was the reasoning that it used? Well, the majority, the two-judge majority, cited the 1990 case of Cruzan versus the state of Missouri that some people may have heard of. This is one of the two most important, Cruzan versus Missouri is one of the two most important legal cases in the United States history. This was a case, for those of you who aren't familiar with it, of a young woman who was in a persistent vegetative state or in a state of permanent unconsciousness after an automobile accident. And she was being fed by a feeding tube, and her family wanted to discontinue the feeding tube, as a result of which she would pass away. And the hospital that she was in the state of Missouri said no. And so the case eventually wound its way up to the United States Supreme Court. And in its opinion, the United States Supreme Court recognized the constitutional right to refuse life-sustaining treatment, right? So now, if any of us wants to refuse life-sustaining treatment, we can do that under the law. And according to the circuit court that heard the Abigail Alliance case, they said that the Cruzan decision implies, quote, that an individual must also be free to decide for herself whether to assume any known or unknown risks of taking a medication that might prolong her life. So we've moved from the autonomy to say no to medical treatment that you don't want to the autonomy to say yes to medical treatment that you do want. And that was an important move that that court was making. The dissenting judge made a number of points critical of the ruling that the majority had held. They said the court should be wary of inventing a new right, and we're inventing a new right here. Second, disagreed that the right of access to investigational drugs was fundamentally rooted in our nation's history. Third, that the majority got its assessment of harms and benefits wrong, and in the opinion of the dissenting judge, opening access up wide would be more likely to do harm to people than to give them benefit. Fourth, that Congress had already banned Laetrile, an alternative medication, and medical marijuana, and the courts had upheld those bans, and that said that our political branches, the Congress and the executive branch, ought to be the ones to make these decisions rather than the decisions being in the courts. So the FDA was not happy, as you might imagine, with this ruling, saying that their regulations were all wrong and they needed to open up the access much more widely. So they filed a petition for the full court, now 10 judges, to rehear the case, the Abigail Alliance case. And now we're in about 2006. And the full court ruled 8-2 against the alliance. So they reversed the 3-judge panel. The 2 judges who'd been in the majority were now the dissenting minority in the full court hearing, and all 8 other judges were saying, no, this was wrong. There is no constitutional right of access to investigational medications. They looked to the other most important end-of-life legal case in our legal history, which is called Washington versus Glcksburg, a 1997 case in which plaintiffs said that there ought to be a right to physician assistance in suicide. And in that case, Washington v. Glcksburg, the Supreme Court said, no, there is no right of physician assistance to suicide because it's not a fundamental right that is deeply rooted in the nation's history. And so we're not going to find a right to physician assistance in suicide. And the Abigail Alliance Court reasoned from that, well, we're not going to find a fundamental right to access to experimental medications either. As another side note, there's a very interesting cast of characters in this DC Circuit Court case. So on the majority, remember, it was 8-2. 2 of the 8 were Brett Kavanaugh and Merrick Garland ruling on the same side of the case. In the minority, the 2 justices, was a judge, or not justices, but judge, was a judge named Douglas Ginsburg. Those of you who are my age or older may remember that name. He was nominated by President Reagan in 1987 for a seat on the US Supreme Court. The word came out that he'd used marijuana as a college student and as a young assistant professor at Harvard. And in those days, a little bit of use of marijuana as a young assistant professor was enough to scuttle your chances for a Supreme Court seat. So he never ended up getting his seat. And the person who ultimately got that seat was Anthony Kennedy. So he went back to being the chief judge of the DC Circuit Court. So interesting that those three judges were all involved in what turned out to be a very important case. And so then the Abigail Alliance was unhappy with the outcome of that, appealed it up to the US Supreme Court. The US Supreme Court refused to hear it, and that ended the case. And so there is, as of today, no fundamental constitutionally protected right to investigational medications in the United States. Let me just conclude briefly by saying a few words about, I think, where we are now. To reiterate, if you want to get access to an experimental drug, there are three ways that you can do so. The first, of course, is to join a clinical trial. And in my view, this is the best way because not only do you get access to that drug, but we all learn something about that drug's safety, that drug's effectiveness. We add to the evidence base so that when that drug actually gets on the market, we know something about how it works or doesn't work and how to use it. But that's not always possible. So the second way is still the FDA's expanded access or compassionate use pathway. And I think that's reasonable or appropriate when there's reason to believe that the drug might do more good than harm, and when you can't join a trial, when a trial is not available to you. It's a good pathway because the FDA is involved. They actually know more than almost anybody else, except perhaps the manufacturer, about that drug, how it works, what to watch out for, what dose to use, and you get to benefit from that knowledge. And also, if there is some sort of serious adverse event, the FDA gets to learn about it and gets to factor that into their decision-making. So we do learn something. The biggest hurdle, of course, is getting the company to agree to provide it, and often, again, they don't. And then the third way, now, as of May 30th, is this new right to try pathway. In my view, it's the worst of all possible ways to get access to a drug because it doesn't really add anything to the expanded access pathway. And we lose the benefits of whatever might be learned from your getting the drug on the expanded access pathway, and you lose the benefits of whatever knowledge the FDA has. The other problem with it is that because there's so little FDA oversight in that pathway, it's prone to misuse by charlatans and snake oil snake oil salesmen who are going to try to sell you things that are going to make them a buck, but aren't necessarily going to help you. Maybe that's like the pagans that Rabbi Lindemann talked about in his remarks. Remember the dilemma we're struggling with, right? On the one hand, we want drugs that our doctors prescribe us. We want them to be both safe and effective for our diseases. And on the other hand, especially when the diseases we have are serious and we don't have good alternatives, we want treatments to be available to us as quickly as possible. And these two things are in tension, the key theme of my remarks. The ideal system, if you could design it, and if anybody here is able to design it, let's talk afterwards, I'd love to hear it. That ideal system lets people have access to drugs when they're likely to benefit from those drugs, protects people from drugs when they're likely to be harmed by those drugs, and makes sure that we can study them carefully so that we can gather the evidence that we need. It's really difficult to achieve all three of these things at once because in order to protect people from drugs, from the harms of drugs, and to be able to study them, that requires limiting access to the drugs until the evidence is in. So either way, you pay the cost of opening access up more wide, or you pay the cost of restricting access. Either way, you're paying some cost. In my view, and this goes a little bit against the grain of, certainly against the grain of what Jordan McLean's mom was arguing for in that little video I showed you, I think there are reasons to be at least somewhat restrictive about access to drugs very early in their development. First of all, very early, the likelihood that they're going to offer any kind of sustained benefit is really very low. Every once in a while, there's a remarkable signal from very early experiments that drugs are just more effective than anything that else that's out there. And then people will move very quickly to make those drugs available, but that's rare. And when that's not happening, the likelihood that people are going to be hurt may be greater than the likelihood they're going to be helped, especially when they're being used not by experts in carefully controlled clinical trial settings, but by people all over the place who may not have as much experience with them. Making drugs widely available outside of trials runs the risk that we're going to reduce the incentive for people to enter trials, and therefore that's going to compromise our ability to get the evidence that we need for safe and effective drugs when we go to the doctor after their approval. And again, the wider the access, the greater the vulnerability to pagans and charlatans and snake oil salesmen who are going to try to make a buck off of offering stuff that may hurt us, is unlikely to help us, but may make them a profit. Some final thoughts. There's no perfect system here. There are downsides, both to opening up access to an experimental drug and sharply restricting it. Either way, we lose something while we gain something. I certainly do believe that there ought to be a pathway for people to get access to drugs that do stand a good chance of benefiting them when they're not able to get them by joining a clinical trial. As I've said a number of times, I always prefer for people to join clinical trials so that we learn something and so that you get them in a controlled setting. But I hope that I've helped you understand why what might seem like the obvious answer, which is to make experimental drugs widely available to terminally ill patients who have no other options, does come with real costs and is actually more complicated than it initially seems. So I will stop there. Thank you again for the opportunity to speak with you and look forward to questions and discussion. Thank you.
So thank you, Dr. Joffe, and Rabbi Wexler and I will be running around with our microphones, and we'll have our first question right here in front.
Dr. Joffe, thank you. That was a great talk. My name is Sandy Gibson. I'm a cardiologist. I wanted to ask you, does the right to try law then allow people to get around a randomized trial to avoid the possibility of placebo? In other words, if I believe that a drug is going to work and there's an ongoing trial, but I know that there's a 50-50 chance of getting placebo, can I ensure that I get active drug by making a right to try claim?
Really glad you brought that point up. In theory, no, it doesn't, because the doctor who requests the drug from the manufacturer is supposed to certify that you can't get it, or you can't, there's no clinical trial that you could join that would allow you at least the possibility of access to it. But you and I both know that doctors are often not going to do that certification or not going to do it right, and will use right to try as a way around the requirement to enter a trial where you might get a placebo or you might not get the drug. Of course, the company becomes a filter for that, because the company may want to see really good evidence that you can't join a clinical trial before they're willing to approve it, because the last thing they want is for you to undermine their clinical trial. So the companies will be paying careful attention to that. I should add that to date, we haven't seen a lot of evidence that major medical centers are on board with the right to try. Most, to the extent that they've been willing to speak about it publicly, most have said, we think that the FDA's expanded access program, which the FDA is also checking to make sure that you are not sabotaging clinical trials by getting drugs through expanded access. Most major medical centers have said, we at least strongly prefer the expanded access program and are not jumping up and down to get on the right to try bandwagon.
Hey, Steve, Bruce Levine. First, thanks for exceptional explanations of the dilemma. And second, of the 1% or the 0.6% of expanded access that the FDA denies, what's the data on percentage of the reasoned and access from companies or not? And I'll close by saying we've used expanded access in our program at Penn, and we've been very satisfied by the FDA response.
I am not aware, and we've looked for this, of data on what reasons the FDA gives when it, in those very rare instances, says no. They published a study of about 1,500 requests for individual patient expanded access, and that's where that 1% number comes from. And in that paper, they didn't give the reasons why they said no. Now, we have no idea how often the companies say no, right? Because there's no central registry of that, because those requests go to the company first, and if the company says no, then nobody ever bothers to go to the FDA because you already know you can't get it. So this is the key thing. I have to assume that if the FDA is saying yes 99% of the time, the 1% of the time they're saying no, they've got a good reason, and it's not arbitrary. But I don't actually have the data to sort of answer that question for you.
We have another question over here.
I'm just curious about the financial aspects of the right to try. We know that new medications are extraordinarily expensive, and when people go into clinical trials, all the costs are covered. Now you're trying a right to try, and what are the financial things? Are we talking perhaps a little elitism where the company will say, sure, we'll provide the medication, it's very expensive, so you're going to pay through the nose. That means, therefore, those who have will get, and those who don't won't.
Thank you. So the companies can only charge their costs of manufacture and the cost that it takes to get the drug into your hands. So they, by law, are not allowed to make a profit on it. On the other hand, somebody who sets up shop and says, I'm going to make drugs available to my patients through Right to Try, the doctor or the hospital or the clinic can charge through the nose for that service. So the companies are not going to be making a profit on that. And in fact, a couple of companies that have thought about doing it, that once they've looked at the financials, they said, no, we're not going to go this route. But there are lots of opportunities for others in the ecosystem to make a substantial profit off of it. And that's where I'm worried about the charlatans who are going to try to use this as a way to get people access to things. There's already evidence. This is not so much under Right to Try. It was actually present before Right to Try. There's already evidence of stem cell clinics. I don't know how many people have traveled recently to Southern California or to Florida, but I was in Florida in the spring, and I'm getting my bag off the bag thing in the airport, and those LCD screens that flash ads that change every 30 seconds. I can't tell you how many of them were for stem cell clinics. And those are all, I shouldn't say all, the vast majority of those are going to be unvalidated, not helpful, maybe hurtful, but it's somebody trying to make a buck off of people who are looking for something to help them with whatever problem they've got. It's a well-documented phenomenon in the stem cell world. I'm worried it's going to carry over to the kind of things that are approved through Right to Try.
Question up front.
I'm just wondering what might be the legal liability that a drug company opens itself to by offering a drug that's not yet been approved or even really tested very much.
First of all, in theory, under expanded access, a drug company could be legally liable for harms from the drug. We have been unable to find any cases of successful lawsuits for that. Generally, patients are taking on risk for themselves and accepting that things could go wrong. So in theory, there's legal risk under expanded access. In practice, it doesn't seem to be a real issue. In Right to Try, there's actually pretty much a total legal protection for the company written into the law, which was the one reason that you might think that Right to Try is more attractive for companies than expanded access is. But companies have never been worried about the legal exposures from expanded access because there are no successful lawsuits. So the protection that they get under Right to Try is probably not very meaningful. There's also legal protection for doctors who might prescribe things unless they're negligent or malevolent or something like that.
You're next. Right up here.
Thank you for being here. And as one of the few lay people here, it was excellent. In other parts of the world, in Europe, where these drugs might be more readily available and the controls are not like they are in the US, are there different results where people are getting these experimental drugs on a free market? And I don't know if that's the case, where the results you could say, okay, statistically, by doing what is going on in Europe, the outcome is completely different versus the stringent controls going on in the US.
I only know a little about the European scene. It turns out that actually most drugs are approved more quickly in the US, despite what you hear. Most drugs are approved more quickly in the US than they are in Europe. That was not always true, but it is true over the last 5 or 10 years. There's no parallel Right to Try experience that I'm aware of. What there is parallel stem cell experience. If you can go to Mexico, you can go to Germany, which actually has pretty open rules around stem cells, and you can spend a lot of money for something that will hurt you. If you go to Mexico or you go to Germany for stem cells, that's the sort of thing that we worry that Right to Try could cause if it is not carefully controlled. So the international experience, I think, is helpful particularly in the stem cell context, which becomes a model for Right to Try. Now, of course, now stem cells are coming to the United States and opening up widely. A couple of colleagues did a study a couple of years ago that showed that there were, I think, 523 unlicensed stem cell clinics in the United States, and that number is probably 3 times that much now, with some really big corporations getting behind sort of spreading these stem cell groups. So now you don't even have to go to Mexico or Germany or India for these treatments. You're welcome to get them. You just got to go to Southern California or Florida.
I wanted to ask you, Bennett, does extended access or Right to Try availability only apply to terminal illnesses, or do they also apply to chronic illnesses that are not life-threatening? And is there a different ethical ladder that we have to cross if we're dealing with non-life-threatening illnesses that have no other adequate treatment?
Great question. I use terminal illness as a shorthand. They actually access is wider than that. So serious life-limiting illnesses that limit your ability to sort of fulfill the functions of your daily life are also eligible if there are no other treatments. And I see the ethics as the same in the sense, but with both expanded access and right to try, in the sense that, living with terminal illness is one thing, but living with an illness that seriously limits your life, that is unrelentingly painful, from which you suffer, I think the ethics are the same there, to the extent that we both want things that work for people, and we want people to be able to get things as quickly as possible that might help them. And I see the calculus as pretty similar. Some of the debate between the House and the Senate was exactly how wide we're going to draw the distinction. I actually don't remember the final language of the final bill of what exactly was the criterion for eligibility, but the intent was not just terminal illness. It also included serious chronic life-limiting illnesses.
Another question up here.
In your opinion, Dr. Joffe, how or would it move the needle on the ethical consideration if, in order to participate in a right to try exercise, we as a society required the recording of all the data on a very granular level of every episode of people, participating in right to try, so that we all as a community could learn from the experience, as maybe not to the extent, you could from a placebo-controlled double-blind study, but it'd be learning. Would that move the needle? Would that change the ethics?
It would move the needle, but it would also turn it into expanded access, because in order to require that, who would require that data collection? Who would be the one to receive it? It would be the FDA. And so now we'd be back to expanded access. Now, expanded access doesn't actually require that granularity of data. It requires, if there's a serious adverse event, then data needs to be reported back. This gets a little bit into the weeds, but in our clinical meeting today, in our bone marrow transplant program, one of my colleagues presented a study that he was going to be opening soon of a new drug, or actually it's a drug on the market for adults that they were going to study in kids. And we had a site initiation visit where the company had done this very careful evaluation of, could we actually carry out the study with high quality? What were our data collection practices? And with good clinical trials, there's that kind of scrutiny of the way that the data are collected. When you move to expanded access, you're moving to places that don't have the infrastructure, that don't have the experience to collect data with that kind of quality. So you can't expect the same high level of data collection, but I think the direction you're pointing in, which again does move us back towards expanded access, is the right way to go. To the extent that we're going to open access up, let's learn as much as we can from that experience. I totally agree.
Question over here.
Hi, I'm Russell Abrams. I'm a neurologist here in Cherry Hill. My question has to do with informed consent. In the right to try, is there clear and coherent guidelines regarding the informed consent that you're required to give a patient before you give them one of these experimental drugs? And does that also include, for the patient's specific condition, what the FDA-approved therapies are? Because some people go searching for things and they don't realize what's out there.
The language in the law is very brief. You wouldn't expect Congress to give us very detailed descriptions of informed consent. The FDA, which still has to write regulations around right to try, even though it doesn't actually formally oversee it, hasn't done so yet. But the Congress's intent, at least, is that there be a clear description, at least of the risks, the fact that this is highly experimental, we don't know very much about it. Congress's intent was that there would be a good informed consent process. You know as well as I do that in some doctors' hands, that's going to be carried out with a great deal of fidelity. In other doctors' hands, not so much. Again, my worry about the charlatans.
Right, and that's what I'm saying. Part of the informed consent should be at least an obligation to disclose what the standard of care treatments are.
Yeah, I agree with that.
So another question over here. We're going to just take a couple more questions.
Hi, I'm a pediatric pulmonologist and a sleep guy.
and I've been involved in clinical trials, and I find the FDA, which generally does a good job, to be wildly inconsistent. On the one hand, I'm sure you're aware of the recent drug for muscular dystrophy that was recommended for disapproval by the subcommittee and yet was approved by the FDA because of parental pressure. And on the other side, I was involved in a study of gabapentin and carbil, which is the treatment of choice for adults with restless leg syndrome, and they were trying to get approval for people less than 18, and the drug is approved for infants for seizures. So you have a drug that's been approved for other indications across the age span, and they're having to spend all this money to show that it can be used in a 17-year-old instead of an 18-year-old.
Yeah, great points. Your first example gives me the opportunity to say there are a number of us that are worried that the FDA, even setting aside expanded access and right to try, is already, because of political pressure and public pressure, understandably, already going too far in the direction of approving things before there's really good evidence that they actually are effective and safe. And as a result, we have cancer drugs that may cost $200,000 a year and that may actually extend life by that much. And the question is, can we continue to do that as a society? And can people continue to afford the $10,000 and more copays that may go along with a year's worth of that drug? The muscular dystrophy example that you point to is probably the most egregious one, where the drug was approved based upon a little tiny signal based upon a change of protein in a muscle biopsy, with no real evidence that kids actually got more strength, walked better, breathed better, those sorts of things. That's the most egregious example, but there's already a tension between how quickly the FDA approves drugs so that we can get access to them more quickly, totally legitimate desire, and how rigorously it studies drugs. And at the moment, the pendulum has swung a little bit in the direction of approving them more quickly, which has some of us worried. That said, when President Trump was deciding who was going to be his FDA commissioner, who he was going to appoint, there were a number of names that were floated that would have swung the pendulum all the way over here, like no rigor in the drug approval at all. Scott Gottlieb ultimately got appointed, and I was worried that he was going to be in this direction. I think he's done a terrific job. I've really actually been very impressed with the quality of his leadership at the FDA and threading this particular needle. I don't envy the leadership of that agency and having to make these decisions between, we want to study things so that we know they're safe and effective, we want to give people access to them as quickly as possible. Somebody is going to be unhappy with you no matter what decision you make.
I want to throw maybe a change up here and get the rabbis involved. I'm trying to frame a question around the concept, can ethics change over time? And so in the legal system, I guess decisions can be overturned or brought up higher in the system. In Judaism, I'd like to know what the rabbis feel in terms are decisions that have been made years ago. Can they be updated? Can they be changed? And in terms of medical ethics, something like that kind of struck me recently. There was a set of triplets that were up for adoption in 1961, and part of a kind of a clinical trial they weren't made aware of. If it was ethical, if it wasn't unethical then, can you look back at it 55 years later and say it should have been unethical then, or it was okay then? So that's more or less my questions.
I want to hear the rabbi's answer. to both questions, actually.
I know I should have said last question earlier when I was over there. Yeah, thanks, Rabbi. I mean, I would say, yes. I mean, no. He's telling me to wait. Okay, so Rabbi Lindemann would like me to to tell all of you that I'm actually at a meeting this afternoon of the Committee on Jewish Law and Standards of the Conservative Movement, which is a group of 25 rabbis and 5 lay people that discuss all sorts of issues of halakha, of Jewish law today. This afternoon we actually looked at 2 papers on a Zoom conference. One is Rabbi Danny Nevins, our friend who has come here, who just when you think he can't write another brilliant paper, pulls out another one where he's writing about the ethical standards that should be employed with artificial intelligence, and that we're seeing more and more of driverless cars, weapon systems, so on and so forth. Really fascinating paper that he put together, and perhaps we'll have him here speaking about that sometime soon. And the second paper is actually a paper that I've been working on with Rabbi Joel Seltzer, the director of Ramon the Poconos, about intellectual disabilities in halakha, about people who have intellectual disabilities and the extent to their obligation halakha and their ability to, say, motzi others, to fulfill others' obligations as well. Frankly, it's something that us, like many communities in the conservative movement, have been involving those with intellectual disabilities for years in our communities, as well we should, and everyone agrees on that. Interestingly, we've never really had an official paper from the movement approving all of that stuff, so Joel and I are kind of filling in that role, and we have the second reading of our paper this afternoon. And the good news is they didn't have that many comments, which is a good sign, because it means we're almost done with that. But there's also issues that we discussed in that committee, and many of them have to do with ethics and law as well. So going back to my original answer, yes, I mean, I think it does happen. You know, one of the more obvious examples, I think, is you look at slavery. I mean, in the Bible, you know, there are laws about slavery all over the place, right? Which, you know, those biblical scholars look at and say, in its context, it was rather progressive in terms of how it was legislating slavery, but certainly not just our context today or in the last 100 years for a little while. Slavery is something that has, you know, I'd like to say universally, is that is totally unethical and is something wrong, and therefore that would obviate those laws because we wouldn't have it anymore. And I think that's a changing ethical perception that's happened over the centuries and many, many years. And I think where it gets really tricky is when you get to those inflection points where a change might seem necessary, right, or might change to happen, where you're able to identify, at least in Jewish law, where you think about how much should we be proactive in helping move this change forward, and how much should we be reactive in allowing the process to play out, and law being a slower movement to then be more reactive to it. And you've seen it in different ways. I mean, more recently in the conservative movement, you know, certainly there are some who see women's participation as an ethical issue, and that has pushed that envelope in the 70s and the 80s in the conservative movement in particular. That was before that as well, but it's fine. The law committee really dealt with it thoroughly in the early 80s. And more recently, with homosexuals, right, in terms of gay marriage and ordaining homosexuals as rabbis as well, which is something else about a little over a decade ago, towards the end of my time in rabbinical school, that was approved and was something that we do. And actually, we'll be having our first homosexual wedding at TBS in January that I'll be officiating at. So it's, you know, and that's something, you know, maybe a generation or two ago, maybe some today too, might see ethical issues with that, but that's something that's evolved as well. So I would say it's not something that we look at cavalierly, and there are those certainly that argue within the context of Jewish law that, you know, no, ethics and halakha are one, ethics and Jewish law are one and the same, or there is no such thing as really kind of this ethics that change. It's always changing, and maybe we have a better understanding of them. But I do think if we just look at some obvious examples, like slavery is what first comes to mind, it is something that can change and can evolve. But how exactly we react to it or are proactive about it is where it really gets tricky. I thought you might.
I think that often when it comes to medical issues, we are reactive because what we're dealing with is a fixed set of texts, biblical, Talmudic, and various law codes, but ever-changing and evolving medical treatments that force us then to go back and review those same texts to see how they would apply to something that we've never encountered before, that could not have been imagined in the past. So we have, you know, all sorts of questions like about artificial insemination and questions now about that are going to have to be addressed. There was just a case today out of China with the manipulation of genes in children And these are issues that will require a review of the texts and searching them thoroughly, and there will be perhaps other precedents by analogy that we can find that will help us to respond.
I'm not sure I can add much to that, except to say that one thing I think is true is that we can get ethically wiser, right? There can be things that may have been perceived as ethical thousands of years ago, slavery, that we have gotten wiser over time, and we now see that they are not. And can we pass a retrospective judgment on those practices a couple of thousand years? We can have a debate about that, but we are not, from an ethical point of view, I think we were not sort of born as a human race fully formed. And I mean, there's a reason we do things like this, is to learn and to grow and to improve ourselves and each other and ourselves as a community. So we can advance ethically, whether there are things that are sort of always right or always wrong. I think there are some things that are like as wrong today or as right today as they ever were. Whether there are other things that could become ethical that weren't previously, or could become unethical that were previously, or is it just a matter of the perception of the time and the culture and all of that? That's above my ethical pay grade. The only thing I'm sure is that we can grow and become wiser ethically.
I think that is a good spot to end on. So I want to say Toda Rabah, thank you very much to Dr. Steve Joffe.